October Public Health Policy Rounds. We're delighted to have you with us today. These are monthly rounds that are open to the general community, the scholarly community, and practice and policy communities that are interested in public health policy. They also serve as a course for people in the collaborative specialization in public health policy. The way we work this is up to 35 minutes for our keynote speaker, today being Natasha Crowcroft, followed by 5 minutes each of discussants. We have one faculty discussant and one student discussant. And then it is the task, the esteemed task, I will say, of the students and others who are in the audience to be asking questions and making and participating in discussion after all that happens. Natasha, you will have the opportunity, if you so wish, to respond to discussion remarks right after they finish, or we can then go directly to the Q&A. We have from 12:30 until 2 o'clock, and I will now introduce our speakers. We'll start. I'm going to introduce all of the speakers so we don't have to interrupt later on. Dr. Natasha Crowcroft is a colleague here at the Dalalana School of Public Health. She's currently an adjunct professor with us, having moved now to the World Health Organization, where she is a senior technical advisor for measles and rubella. Natasha has a decade of international work on measles and rubella elimination, and as an expert member of the SAGE working group on measles and rubella and various other working groups that I'm not going to go into. She was a member of the Independent Review Committee of Gavi 2018 to 2020 and has conducted technical work for the WHO on other vaccine preventable diseases, including developing the methods for pertussis global burden of disease estimation. She is also a senior fellow at Massey College at University of Toronto and was the inaugural director of the Center for Vaccine Preventable Diseases at U of T. Previously, she held appointments in laboratory medicine and pathology and was an adjunct scientist at ICES. She's got many other accolades. She was a part of the leadership team of Public Health Ontario and finished there as the Chief Scientific Officer. Her training is as a physician with a doctorate in medicine and public health at the Universities of Cambridge and London, UK, in the field of epidemiology in the European Program for Intervention Epidemiology Training. And she has a large number of scientific papers. So Natasha, it's a real delight and privilege to have you with us today. And I will say that Natasha is giving up time on her Friday evening and being stationed now in Switzerland. Xiaolin Wei is a colleague also at Dalalana. He's one of the mentors in this program. He is a medical doctor, public health specialist, professor, and he is the Dalalana Chair in Global Health Policy. He became a fellow of the Faculty of Public Health of UK in 2012, and his research is focused largely on implementation science frameworks to change clinical practice and make impacts at the policy level in areas of microbial resistance to TB control and diabetes hypertension care. He also has numerous peer-reviewed research papers and has been principal investigator of very impressive grant programs. So thank you for coming today, Xiaolin, to do the discussion remarks. Finally, Franklin Perez, one of your own, I will say. He is a colleague. He's one of the student trainees in the collaborative specialization in public health policy. He completed his master's at U of T on antibacterial nanoparticles and is currently doing a PhD here at U of T as well. And he aims to contribute to infectious disease policy by showing whether nanoplastics are making bacteria more resistant towards treatment. This is rather an unusual and extraordinary area of research, unusual in the cloud specialization in public health program. He's interested in how infectious disease policies are determined and the factors which influence policy change, and hence he's in the collaborative specialization. So that's it for me. I'm not going to speak very much for the rest of this session. I'm very delighted to hand it over to Natasha, who is going to share her screen so you can see her slides as we go along. Please feel free to turn on your cameras. It's always nicer for people presenting to see at least some faces and some responses. So if you can and you're comfortable, please do so. Natasha.
Thanks very much. Okay, I'm going to share my screen now and hopefully this will work.
Yep, we can see it.
Okay. All right. So hi, everyone. Greetings from Geneva. I'm very pleased to be speaking today and speaking about one of my favorite topics, measles. So what I'm going to talk about is going to be in 5 sections, which is more than I usually do, but I was trying to organize my thoughts. So I'm going to start off with some global context, because I guess not everybody's starting in the same place. And then I'm going to talk about the measles elimination policy and what happened when it was implemented, so you can understand some of the challenges. I'm then going to talk about how the strategy changed, then how the context changed, and then draw some conclusions. So to start off, in my first section is about the global context. And all of the pictures that you see in this are from an artist called Sophie Blackall, who did some amazing work for the Measles and Rubella Initiative. And they're all on the Measles and Rubella Initiative's website. So that's if you're wondering where these lovely pictures come from. So I'm going to start off, my first bit of context is what is a vertical program. So referring to the title, and this is, this comes from a couple of publications by Ken Cross and colleagues and by the World Bank. So, so a vertical program, it's a component of the health system which it's specific, it has defined objectives, usually it's short or medium term. There are strong centralized technical and financial management and funding arrangements. Actually, can I just check, is the participant screen interfering with you seeing the slides, or because I can see
people can play with their own participant screen.
Okay. All right, good. All right, sorry, because it's I wasn't sure whether you were seeing mine. Okay, great. So it's, I mean, it is what it sounds like. It's a very focused top-down approach, and because of the way it is, the efficiencies and the simplicity and the focus on one thing, it's often very appealing to people who are trying to get rid of one problem, so eradication or elimination problems. But it's also very appealing to donors because they can see, you know, what it is they're giving money for and what the impact is likely to be. So it really implies a very selective targeting of specific interventions rather than something that's fully integrated in health systems. In contrast, a horizontal program, you're talking about multiple services delivered through generally publicly financed health systems. Commonly, when in the context that I'm talking, we're talking about comprehensive primary care, and really the oldest of the 2 modes of delivery were derived from primary health care, which originated as part of the Alma-Ata Declaration in 1978. So these 2 approaches have been, I mean, it's a long, long history of people batting backwards and forwards between vertical and horizontal approaches. So this is nothing new. And when we talk about immunization programs, we talk about a mixture of both. So there are immunization programs delivered through vertical and horizontal approaches. And before I get into that, I wanted to say, for those of you who are not on the immunization side of things, just to reinforce that immunization programs are not as simple as they might seem to some people. Infectious diseases are social diseases. We've seen that with COVID-19. And immunization programs are really social interventions. So everything you get in public health and everything you get in policy issues. It all comes up in immunization. The whole world is in there somewhere, which is one of the reasons I like working in this space, because there's every challenge you can imagine. So successful immunization programs, they really need to be strong in multiple dimensions. And, you know, setting aside just having a safe, available vaccine that's provided for free if it's going to be really successful, you also need strong surveillance and monitoring around a program. You need a healthcare system that can deliver it and that is equitable and accessible to people. You need vaccine supply systems, which are another whole world of things to think about. But then you also need communities that accept vaccines, that are confident. You need policymakers that are working behind the scenes to make policy. You need politicians on side, and you need all the evidence that goes into setting up a good and effective immunization program. So there's a lot of pieces to immunization programs. And in an ideal world, they are delivered in a country like Canada through a horizontal approach with the support of a primary healthcare system. But that has not been the way in which we've achieved elimination or indeed eradication. And those programs have been delivered so far in the history of immunization through vertical approaches. So what do I mean by elimination and eradication? Elimination means reduction to zero of the incidence of disease or infection in a defined geographical area. So when I'm talking about measles or rubella, in fact, elimination means no ongoing transmission for more than 12 months. And the verification process kicks off after 3 years of elimination. So when we talk about verification of elimination, it means elimination's been in an area for at least 12 months. When we use the word eradication, and this is all purely jargon, so I'm just making sure we know what people mean by these terms. Eradication means permanent reduction to zero of the worldwide incidence. So when it comes to vaccine preventable diseases, we've only done that for smallpox, and we're very, very close with polio, but we haven't got there yet. And we haven't got close to eradication with measles. But measles elimination and to an extent eradication has really been the policy for a long time, and the world's been working towards that for a long time. And as I said, taking the approach of a vertical program. And the basis for that was this idea that it was feasible, and these three biological criteria that exist that are deemed important for disease eradication, they all apply to measles. So we have humans are the only reservoir, we know how to diagnose this disease, we have an effective practical intervention, i.e. immunization, that's available at such reasonable costs that measles vaccination is actually one of the few things that's cost saving. It's not even cost effective, it's cost saving. And so the view was, until very recently, that the challenges for measles eradication were a logistical challenge, a political challenge, a financial challenge, but not really a technical challenge. The other thing I wanted to emphasize, because this is a group that's interested in policy, is this idea of measles and equity. There are lots of different expressions, sort of taglines applied to measles. It's been called the canary in the coal mine, a tracer of other problems with immunization, a sign of bigger problems. It's also been called the equity virus. And the reason for that is because measles is so infectious, you need to immunize virtually everyone to get this disease under control, to eliminate it, and eventually to eradicate it. And because of that, really, you actually have to have equity. And there's been some nice modeling work showing that if you, the more inequitably immunization is distributed, the less likely you are to bring measles under control. So that's a really important piece to the discussions around policy, and another thing that's driving this idea of measles being something we want to eliminate. And if we do eliminate it, we achieve equity. Measles vaccine also dominates global return on investment in immunization. So this is a recent publication came out just this year showing the taking a cost of either a cost of illness or a value of life approach to evaluating different vaccine preventable disease, different vaccines. And this big blue block in the middle is measles. And you see that across all countries and all years, measles accounts for 76.4% of the benefits based on a cost of illness approach. So it's a massive component of the benefits and the return on investment in immunization. So I'm kind of arguing the special case for measles, but it's not a hard case to make. The other thing I wanted to talk about is the structures around immunization decisions and some of the partners. And there's a huge number of these, so this is a whistle stop, but just so you have a sense of this, the headquarters of WHO in Geneva, which is where I work now, and that has a department, Immunization, Vaccines and Biologicals, which is where measles sits in the scheme of things. And that is advised by the WHO Strategic Advisory Group of Experts. WHO regional offices are fairly autonomous. They're not really departments of headquarters, which some people think they are. Have a huge amount of expertise, and obviously the country-facing piece of the World Health Organization. For example, the Pan American Health Organization has got a longer history than the World Health Organization itself. So they have a lot of autonomy and incredible levels of expertise. And then the countries themselves have their national immunization technical advisory groups and NITAGs. There's also regional equivalents of those committees. And then in federal countries, there are subnational decision-making in many of them. So for example, in Canada, the decision-making actually happens at provincial and territorial level, although there is a national group, but the decisions are made at subnational level. And then there's a whole range of partners in addition to the World Health Organization with at global level, including UN, UNICEF, the UN Foundation, Gavi, very important for Gavi eligible countries. Those are the countries that are that face the most financial and organizational and other issues in accessing immunization. The Bill and Melinda Gates Foundation, a huge player in the global field. The US CDC was until recently a major supporter for WHO. The Measles and Rubella Initiative, which I mentioned earlier, which is a partnership of different organizations that come together around measles and rubella. And then others, including the American Red Cross and many others. So it's a very complex environment in terms of decision-making and in terms of donors and partners and funding. So that's a very rapid sort of piece of, or touching on lots of different pieces of context. So I'm going to move on to the elimination policy itself. And I wanted to say something about targets that have been set. And there's a million targets out there. Just to say that until very recently, there was a global vaccine action plan that ran up to actually 2020, which included regional elimination goals. And these were by 2015 to achieve elimination of measles in 4 WHO regions, and by 2020 to achieve elimination of measles and rubella in 5 WHO regions. I just have to say that neither of these were met. Neither of these 2015 nor the 2020 targets were met. And that's not necessarily a big deal. Targets are not always met. But there is a story behind that, which I'm going to talk through and try and bring us up to how the policy on elimination changed and what that means moving forward. So to go on with the story of this, I wanted to talk a bit about what happened in the Americas. And following this goal, I mean, the Americas have led the way in elimination of smallpox and elimination of polio, both of which were achieved here first. So it was really not surprising that in 2010, the Americas established an international expert committee to verify the elimination of measles, rubella, and congenital rubella syndrome. And an incredible amount of work had led the Americas into the position of being able to even embark on this process with very strong work to strengthen immunization programs at country level, with lots of support from the Pan American Health Organization, and also very regular campaigns to catch up countries and get them in a position to verify that they had eliminated measles and rubella. So lots of work going on. And I don't know if any of you are aware of which country, when this process kicked off, was the first one to threaten this process. And I was a member of the committee. I'm in that black and white picture that I just showed of the committee members. I can't see the chat line right now, but you might be surprised to know which country was the first one in 2011 to get us worried that we might not achieve elimination in the Americas. And I'll give you the answer on the next slide. So it was actually Canada. So in 2011, there was a huge outbreak of measles in Quebec, which very nearly went on for more than 12 months, which would have meant that the whole of the Americas lost its elimination status. So as the person from Canada on the committee, it was a little bit awkward for me. Anyway, Canada managed to pull itself back from the brink. But a few years later, a big outbreak started in Brazil, and the map on the right is showing you the little red dot in Brazil that turned into a very big outbreak. It actually, the whole thing started off elsewhere, as measles outbreaks obviously often do, but in 2015 it did take off in one state in Brazil and carried on for more than the 12 months. So it took some work to bring Brazil back into the fold again. And Brazil was again a surprise, like of all the countries in the Americas that would have issues with sustaining elimination, Canada and Brazil were not the two that would have been top of our list of concerns. Anyway, the work was done. And in 2015, we were able to announce elimination of rubella from the whole region of the Americas. And in 2016, we announced elimination of measles from the whole of the Americas. So this was an amazing achievement, and we felt, absolutely like we proved it could be done. And now it was just a question of trying to get the rest of the world to catch up and get the job done there too. Of course, that's not how it worked out. Everything didn't carry on as we envisaged. Venezuela had this incredible political crisis. Measles resurged in Venezuela, and it spread to countries all around it. It spread to Costa Rica, it spread to Colombia, and it spread most tragically into the Amazon basin, and it had a terrible impact on the indigenous people in that area, and spread into Brazil. And Brazil has been struggling with measles since then, with a huge resurgence. So the Americas has lost its measles elimination status, and Brazil in particular has been fighting to try and get it back under control. In 2019, it felt like measles was everywhere. It was a massive year. You see this big peak in 2019. The most cases in that peak are actually in the African region, but there were a lot of cases in Brazil as well. So a really, really bad year for measles, and very disappointing after the success of 2016. It seemed an awfully long time ago in 2019, but it just shows how quickly things can go wrong from that low point. So what this also shows is that there's not that much going on in 2020, and there's a few reasons for that. One is that we're in a post-epidemic period, but the other reason for that the low numbers of reports in 2020 is because surveillance is really not happening due to COVID. And it maybe there's an element of measles also not spreading because of the lockdown and reduced travel, but also the labs have been diverted into working on COVID-19. So those increases in 2019, it was actually the most cases since 1996. So it wasn't just an increase compared to 2016, but really, the biggest number for nearly 20 for over 20 years. So a really, really massive increase, and can be attributable to really flat immunization coverage, global coverage hovering around 84 to 85% for just far too long, and eventually that accumulation of susceptibles, that immunity gap, caught up with us with this explosive outbreak. So this led to the SAGE, the Strategic Advisory Group of Experts I mentioned previously, coming up with a measles eradication feasibility assessment. So a massive pivot, big change in direction, in which the committee said, right, forget it, we can't really have these targets. We've got to stop and think again, and not even think about setting an eradication target date until we've made measurable progress towards achieving country and regional elimination goals, and the strategies and resources and commitment are in place where the world is ready for a time-limited intensification of efforts. We're just not anywhere close. You know, we've had one region achieve elimination and lose it within 2 years. So this is just not going to fly. It's a big, big change in direction. Now, having said all of that, at regional level, the regions still have elimination targets, and they're still working towards them, which is, you know, there's a huge commitment at country and regional level to keeping going, which is, you know, incredibly commendable in the context of all the challenges. And there's still progress. There are countries, you know, we've got 83 countries as of September this year that have achieved a measles elimination. So the work is carrying on at local level. It's been a globally, there's been this, you know, stop, let's think again. Regionally, there are still processes in place, and they're still moving forward. But this global change of strategy, so you know, I've talked about some of the contextual changes, but diving a bit more into the details of it, you know, we've seen a shift of epidemiology in measles, and it's shown a shift towards both young infants and young and older age groups. So there've been these unaddressed immunity gaps. Some things I didn't mention, that healthcare-acquired infections have become played an increasing role in sustaining outbreaks, which really need to be addressed. There's also been clear recognition that certain groups have been left out and are causing major issues in driving measles and sustaining measles. And then at the same time, this declining appetite for vertical disease control programs and for non-selective country-wide campaigns. So in the Americas, there was a very strong part of not just strengthening healthcare systems, but also recurrent campaigns to catch up when healthcare systems couldn't keep up. And that very widespread campaign approach has become increasingly questioned, because in the polio context, you know, the same kids being immunized again and again, and the same kids being left out. So again, this vertical and non-selective, a vertical approach to programs, and this non-selective approach to campaigns, the donors in particular losing appetite for those approaches. The other thing that was recognized very strongly was the problem of health system weaknesses that have led to the low coverage, and needing to address this. The fact that the health system didn't have a mechanism for catching up older children and adults, then vaccine hesitancy becoming an increasing issue, and surveillance quality and monitoring, so not having the data that we needed to guide decision making. So as a result of all of this, there have been the development of global strategies. Immunization Agenda 2030 is the overarching one that the World Health Organization has launched. It's been approved by the World Health Assembly, which includes measles as a tracer within that. So it's measles is being used as a way of showing problems in the healthcare, in the immunization system and in the healthcare system, weaknesses and gaps. And as really an annex to IA 2030 is this measles and rubella strategic framework, which I'm going to talk about. And I'm going to whiz through it really quickly, but just to highlight some pieces of it that relate to this idea of switching from a vertical to a horizontal approach. And then as a really almost as an annex to that is the Measles Outbreak Strategic Response Plan. So that's a specific piece of it that's dedicated and isn't ready yet for prime time, but is dedicated to specifically addressing the prevention and rapid response to measles outbreaks. So the Measles and Rubella Strategic Framework is fully aligned with the Immunization Agenda 2030, as I mentioned. It has a vision of a world free from measles and rubella, and it has a goal to achieve and sustain regional measles and rubella elimination goals. So it has visions and a goal that sound very much like what we had previously in terms of a vertical approach. But the strategic framework is really not vertical at all, because it's expecting to achieve increased coverage with routine immunization. So it's very focused on strengthening routine immunization, which requires health system strengthening. It's focused on reducing immunity gaps, achieving equity, more effective and efficient supplementary immunization activities. That's moving away from non-selective campaigns to more tailored approaches. It's also strengthening outbreak response, as I mentioned, and then this idea of having better data, so improved surveillance and immunization data to guide decisions, which is also all about strengthening systems. So it includes these key pivots. The strategic priorities are framed as pivots, so they're changes. And when the things I've underlined here are really about the primary healthcare systems, universal healthcare coverage, comprehensive surveillance platforms, improving ownership and accountability, but not just for the communities, but political commitment. It includes identifying and closing immunity gaps, which is speaking again to underserved populations, achieving equity. It includes life course integration, so it's not just thinking about, in many countries, immunization has really been thought of as a thing that only happens in the first year of life, or even in children 9 months and under. It's really focused in many countries on very young infants, but we're moving that into the second year of life and beyond. So that's a big change as well. And it supports catch-up and, again, increasing equity. It includes reducing morbidity and mortality through outbreak response. It includes supply and sustainability, sustainably financed. So that is speaking to moving away from rescue packages to getting really engagement of countries. And then finally, innovation. And that is all about, we can't expect different results if we carry on doing the same things we've already been doing. So we do need innovation, which means we also need research and evaluation to support innovation. There are core principles that are taken straight out of Immunization Agenda 2030 about being people-focused, country-owned, partnership-based, and data-guided, which really, I think all of this language is about strengthening countries and strengthening systems and being very horizontal in the approach. And it also includes accountability, monitoring, and evaluation. So indicators, targets, and milestones with a monitoring, evaluation, and action framework, which hasn't been developed yet, but the one for Immunization Agenda 2030 is in the process of being finalized, and this will build on that with a system for oversight as well. So I've really been trying to, talking about a strategy is always it's not the most exciting thing in the world, but although it is, if you're kind of involved with it and try and see, and you really feel the vision, which is about strengthening systems and reaching kids and equity, like all of those things are very exciting, and using measles to drive that in a way. I mean, measles, it is a bit special in the sense that if you don't get things right, you will find out. Measles is the first vaccine preventable disease that's going to jump up and tell you that you're missing something. So I hope all of that, to put that into some context, that has given you a sense of how things have changed in how people are thinking about this. But the other thing that has changed is the context right now. And so I can't talk about anything in terms of infectious diseases without mentioning COVID-19. But even here, when you look at what's going to kill children, measles is going to kill children unless we get on top of it. And for all the things that are going on with COVID-19, one of the big effects that has happened is a disruption to routine immunization. And there are lots of concerns that this is going to put lots of people at risk. So there's a paper that came out in The Lancet a couple of months ago, has some modeling work to look at what the impact of a disruption to routine immunization would be compared to continuing immunization. And and it's clear the benefits overall, the benefit risk ratio is very strongly in favor of immunization, of continuing routine immunization. And when you look at why it's such a huge benefit, the dominating piece is measles. It is really the largest component of the whole benefit of continuing immunization is measles. And a similar analysis during the Ebola outbreak also found that the disruptions to measles immunization during the Ebola outbreaks in West Africa could cause more deaths than had actually happened from Ebola. So really important to carry on immunization in this context. And yet campaigns are postponed because of COVID-19 for all antigens, including measles. And this is data up to the 21st of September, so relatively recent. And in the analysis of how many kids are missing out due to delayed measles campaigns right now, it's 107 million people are missing out on immunization because of delays to campaigns in 27 countries. So we have a current issue right now that really needs to be addressed as soon as possible. The same issues are actually affecting polio in terms of delays to campaigns, but polio is another massive, even bigger vertical immunization program. And they're also right now considering the same issue of how do we move from a vertical program to a more horizontal approach for all the same reasons that measles are facing. And we don't exactly know how to do that, but there is a determination to do it. I mentioned innovation. We do need to innovate, and here are two ways in which we have innovations that are in the pipeline, which I hope get accelerated, and I hope COVID-19 gives us a way to accelerate these with all the changes, the importance of laboratories, as you know, in COVID-19, the importance of being able to innovate in vaccines. Microarray patches are these, they're like Velcro. It's a bit like Velcro that you stick on the skin and immunizes. So it's an incredible step forward to move away from needles. And it's a bit like the opposite of what's happening with polio. Polio is moving towards injectable vaccines for safety reasons. This is a way of moving towards lower tech delivery of measles vaccines, which would make achieving equity even easier for measles. And then there are these rapid diagnostic tests being developed, which could transform the way in which surveillance is done by reducing the burden on laboratories in terms of diagnostics. So there is innovation in the pipeline. What we're discussing in terms of how to go about moving to the vertical, from vertical to horizontal, I think is quite interesting. There's this discussion of, well, you know, how do we do it? And so Walt Orenstein and some of his colleagues have come up with this idea of, well, maybe we can come up with some middle ground where it's a diagonal approach, where we get, you know, the efficiencies of the vertical approach with the strength of the horizontal approach, and the, you know, the combining the multiple benefits of the horizontal approach. So this is an image of how to maybe do this. And I mentioned the second year of life as being a step forward in trying to get a second dose of measles vaccine available for kids, and it also is a platform for delivering other vaccines like yellow fever vaccine and other vaccines, but also to catch kids up. So if there's another opportunity to reach them when they're 2, or maybe if their mother comes in with a new baby and they have a 2-year-old with them, then maybe, you know, that's when they can catch up both kids at the same time. So you know, using I've talked about using measles as an indicator of health system strength. You know, there are many ways in which we can think about it, but it's been framed as a diagonal approach of trying to get the best of both worlds. The bottom line is we're not sure exactly how to do this yet. And I think anybody who's interested in implementation science as an area, there's some really interesting work to do on the ground to research these questions of, you know, how do we do it? Because it's very locally tailored and very contextual. So hopefully I haven't gone on too long. I better move on to some conclusions and acknowledgements. I think moving from vertical to horizontal it's a major complex policy change. I mean, it requires these things I've been talking about: primary healthcare, health systems access and strengthening, this idea of moving to a life course approach and integration across programs, strengthening surveillance and getting better data and better capacity to do the data analysis and decision-making skills that are needed. It also requires innovation, research and evaluation. I think it's really interesting that we are at global level moving in this direction. But at local level, I'm not sure we have answers to all the questions we have about how to actually do it. And so here's an opportunity for the University of Toronto to help us move in this direction. And I look forward to hearing what our discussants have to say and whether they've got any ideas to help us do that. So thank you. And there's a huge number of people. I just put this up not for you to read, but to see the numbers of people who are involved in developing a strategic framework like this. And you know, it took over a year to develop that strategic framework, and huge numbers of partners and individuals involved in doing that. And thank you very much for listening.
Well, thank you, Natasha. That is an incredibly comprehensive view of a huge issue and a tremendous amount of work that's been done over many years in a short period of time. So thank you so much for sharing. I obviously, as always, have a bunch of questions, and I'm going to restrain and turn over now to Xiaolin for his discussion remarks.
Thank you, Robert. And also thank you, Natasha, for this wonderful talk. I think that is really the direction for many disease control programs to move from vertical system to a horizontal system. For example, I have seen that program has been successful in many countries for immunization program, for TB program, and for HIV program. There are a bunch of advantages they can count on the horizontal program, especially the primary care programs. For example, they're usually the first contact care. They're closer to the communities, and they provide a comprehensive care with different communicable disease and non-communicable disease care. And they tend to recognize the person as a person rather than a patient. But on the other side, I want to also point out there are lots of barriers as we are moving forward. And I have seen these barriers, for example, like moving HIV care in sub-Saharan West Africa, and also moving the tuberculosis care from the designated TB dispensaries to the primary care and district hospitals in China. For example, one of the challenges that do primary care organizations or facilities have enough resources. There's usually like one team or one doctor are doing multiple tasks. They have to do immunization. They also have to do the chronic disease control like hypertension, diabetes management. And there's also a problem to say how the primary care facilities are connected to the immunization programs. In many countries, immunization programs, or even in the high income countries, they are provided from certain organizations. So there's need a connection between them. More challenges in many African countries, and because they simply do not have primary care facilities. And if you look at the basic level care they can access, they will be either private providers or a district hospital, which is still like 10 miles away from where they live. I think we also need to recognize how we could achieve that during the COVID pandemic. From my research, for example, I do the research on how to reduce antimicrobial resistance by reducing the use of antibiotics for upper respiratory tract infections. And during the pandemic, we can see there was like 50 or over 50% drop of the visits to the primary care facilities, because primary care facilities would never see patients with fever or any kind of similar symptoms to COVID. So we need to think about a patient triage system. We need to think about integrated management for example, like integrated management guidelines for adolescents and adult units, which was raised in WHO a number of years ago. And also we need to clearly define the roles of primary care providers in treating flu-like units, because that will include COVID and include how to triage COVID. And unfortunately, part of symptoms of measles would be similar to COVID. So patient might be afraid to go to the primary care facilities to be treated. So I think those are lots of questions we reason, but I think as Natasha said, we need design from the WHO and also from regional and country levels. We also need implementation science to see how these guidelines could be integrated and who should be providing that, and how the context is going to shape the different adaptation of this international strategy. That's me. Thank you.
Thank you so much, Xiaolin. Many questions. I'm afraid if we keep going on, we're going to have more and more problems on our hands. I'm wondering, Natasha, if you want to have any short response to Xiaolin before Franklin comes on?
Sure, yeah, I mean, I agree with everything you said. I think the issue, you know, this is a strategic framework that is being, has got support at global level. When I presented it at the SAGE, Seth Berkley, who some of you may have heard of, who's the head of Gavi, said, he actually said superb twice, which apparently he never does when you, so, you know, it's got a lot of support. You know, it's just the devil's in the details of how you actually implement. And if there is no primary healthcare system to speak of, then there's nowhere to implement. And we can talk about horizontal programs, but switching strategy doesn't create resources. And that's the fundamental problem. And the countries that are struggling the most don't have anything to even build upon. So the reason that vertical programs and and big campaigns are most prominent in those countries is because they're relying on rescue remedies. They're relying on, you know, we have to go in, and that's the situation right now in the COVID. It pushes you towards a vertical approach because you can see the risk of polio and measles and other outbreaks just accumulating. And so people just need to get in there and stop it happening. It doesn't promote, you know, all that careful, longer term work to build a primary healthcare system. But having said all of that, lots of low-income countries have managed to do it, have managed, if the country, you know, given a stable state and political determination, a low-income country can build strong primary healthcare. And you've seen countries have ended up with lower infant mortality than the United States, for example, by doing that. So we know it can be done. And so we have to live in hope.
Thank you. And Franklin, thank you for your patience. And I'm delighted to ask you to give your discussion remarks now.
Okay, well, thank you, Dr. Schwartz, and thank you, Dr. Crowcroft, for your presentation. I want to talk about polio integration and how it can be used to push forward a window of opportunity for measles. And do you think if COVID-19 can be slowing down that window of opportunity? And for my second question, can we talk about the reasons why like there's a slowing down of the programs for measles. Like there could be inadequate surveillance, there could be vaccine hesitancy. And while inadequate surveillance is a role played by government and individual stakeholders, vaccine hesitancy is more of an individual perception. So I'm interested in knowing what role public perception and individualism plays in immunization programs, and if there's serious consideration in making vaccinations mandatory.
Thank you, Franklin. Natasha?
Okay, great questions. So I think what I just said in my response to Shaolin about the emergency pushing people towards vertical programs, I think on the surface that sounds like it might be slowing down the opportunity to integrate with polio and come up with a joint, comprehensive and horizontal approach. Interestingly, I'm not sure whether that's actually the case in reality though, because I think the fact that polio and measles, I don't know this for sure, but there's a possibility that we may be able to combine forces in starting by having combined polio and measles rescue missions, which is a vertical approach on one level, although it's just adding two things together. But you'd have to kind of understand how separate polio has been from everything else to know that that would be a step in the right direction to getting getting some alignment and forging some connections, and could be a springboard towards a more horizontal approach in future. So I am hopeful that it will. It is slowing down. It may not work, but it's possible that we could actually achieve something. On the, you're absolutely right on inadequate surveillance, and the government's, that's been a really critical part. Inadequate surveillance and monitoring, so that not having good enough coverage data, not having good enough disease data, it's absolutely critical, and it's really part of an immunization program. You have to have the information systems. And lots of countries have really suffered for that. So that's been a really important part of the whole thing. And I think the role of laboratories is critical. We need, and I really hope that COVID will just make it so clear how badly prepared the world was. It was actually going the opposite direction, taking money out of the laboratory systems when it should be putting money in, and how important that is for immunization programs and for infectious disease control in general. The vaccine hesitancy is really interesting. It's played a really big part in some outbreaks, but it's not the major driving force behind most of them. And so one of the things that, although it's a huge issue, it has to be addressed. What worries me is that it's very easy to blame parents for what's happening. And I think the system issues are much bigger. And parents are often hesitant because they hadn't had a good experience in the health system. So there was one of my colleagues was saying that they were trying to figure out whether there was a big issue with vaccine hesitancy in a country, in a low-income setting. And so they were thinking, the parents are hesitant, they're worried about vaccine safety. And then they looked at what the issue was that determined whether or not kids got vaccinated. And one of the key things was whether or not a healthcare provider was friendly. And so, which is, it's obvious to any of us who's a human being that you're more likely to feel better about getting your kids immunized if the person you go to see is friendly. And you don't really think that you should have to tell healthcare providers to be friendly. But I know, and everyone knows that, you go to healthcare providers anywhere in the world and they're not necessarily friendly. So, the person you meet on the front desk isn't necessarily friendly. So if that's a really important thing, then maybe that's something simple. What can the system do to make it easier to get immunized? And sometimes it's not about throwing money at problems. It's about really simple things about the quality of how people are approached. So I wouldn't want to blame parents for what's often a system issue. And there are some practical things like, are the clinics held at times that working parents can get to? And in certain environments, the when you look in low-income settings, the services that have been hit hardest are the outreach services. So what they call fixed post, where you have a building where an immunization clinic is held. They're not as badly affected as the ones where you have to go out to find the kids that are being missed, or you have to transport everything out there to reach them. And that's not surprising because travel's been curtailed. But that's a service issue. It's not a hesitancy issue. Having said all of that, vaccine hesitancy is a problem, and we need to have good communication. And I am concerned about the COVID vaccine potentially promoting vaccine hesitancy. Any issues we have with a new vaccine are going to really amplify that. That's one of the concerns about joining up measles and polio. If you think in some parts of the world, polio's been intensely politicized. When Osama bin Laden was executed in Pakistan, that happened as a result of using the healthcare system to find out information about someone, and that caused a huge problem with the polio program. And many polio workers have been murdered as a result of that. And the polio vaccine has become intensely politicized, and so which is terrible, and so measles, there's some nervousness about aligning those two programs together for that reason. So I'm not saying that's going to be a deal breaker, but it just is. It's very complex. So your question about mandatory immunization, well, some countries have found it a useful tool. I think Ontario has an interesting system where people call it mandatory, but it isn't. Every child can get an exemption in Ontario, and it's really mandatory declaration of the status of your kids, and if you want to use the public education system. So it's a kind of interesting compromise on that. And when the last surveys I've seen of what parents think, most parents in Canada support vaccination being truly mandatory. So if you take a democratic approach to it, then maybe mandatory is the way to go. I don't know. It depends on your view of the world. I think the Ontario approach is quite a nice one, because it makes it clear that this is seen as something that's a parental responsibility that goes beyond their own kids and to the risk to other kids. And it also enables public health to know who those unimmunized kids are in case of an outbreak. So I think it's a sort of reasonable compromise. But in Europe, many countries have found that's not adequate, and they've instituted really significant fines for parents who don't get their kids immunized.
Okay, so many interesting things that we could actually spend a lot of time on each of these questions. Thank you, Franklin, and thank you, Charlene, for your really stimulating remarks and questions. I want to open it now because there's lots of people out there. There's a bit of chat with mostly just comments and gratitude for the tremendous presentation. So we should feel good about that. I would like to now to open up the floor. It's probably best if you raise your hand with the Zoom hand raising function, or you can also write a question or a comment, something you want to discuss in the chat. So we're open. Please come forward.
Can I ask a question?
Yes, please do.
So thank you so much for the presentation and for the comments. Are really, really helpful and really informative. I had a question, and that was in relation to skepticism, which is a really interesting point, because I had a friend who was, going to take the child for vaccination, and they were very kind of surprised about how pushy the healthcare provider was, and like they were pushing it, and they said, "Well, I'm not really against it. I just, I was asking information, questions just normally," but then they felt that it was very pushed, and they were kind of very hesitant at that point. So my question is, how can we deal with skepticism in terms of big pharma, and how people are trustworthy in terms of the medications and the vaccines and all those sorts of things that we have right now? How can we address that issue because it's definitely increasing. And as you mentioned, in terms of COVID and anything that could go wrong with the vaccine, that could have negative implications on other vaccines like polio and measles, et cetera, et cetera.
Natasha, do you want to collect a few questions, or do you want to go one by one?
I can do one by one, unless, yeah.
Go ahead.
Yeah, sure. I'm happy to do that. Give people a chance to think a bit about what they want to ask. Yeah, thanks. Great. That's a great question. My personal view is that the key thing is the relationship between the healthcare provider and we're usually talking about a parent, obviously, but then, you know, as people grow up, then it's about their own immunizations, but normally we're talking about the parent and the healthcare provider. So that relationship is what's absolutely key. And so that's where I mean, when I was, that was a focus when I was at the Center for Vaccine Preventable Diseases as a director. That was where we were thinking, how do we address vaccine hesitancy? Well, we need to get healthcare providers confident in what they know and understanding how to approach parents in a way that makes them comfortable and feel able to ask any questions and not and go away and think about it and come back or whatever, but not feel they're being pushed into anything. And you know, the days have gone, and I think, I mean, very few healthcare providers are, you know, think that it's still a time where you can just tell people, do it because I tell you, you know, like that's just not in anybody's ethos. But if parents are feeling like that, then that's obviously not a good outcome. The big pharma thing's a bit trickier because honestly, I don't think that's ever going to go away. And I, you know, it's become this kind of mantra. And the fact is that governments a long time ago decided they were not going to be in the business of making vaccines. I mean, some countries do still make vaccines, but very few. Canada stopped, the UK stopped, you know, most countries, it's now private sector. It's not a thing that governments feel that they should be doing. And so you're going to have pharma. And when it comes to buying acetaminophen or getting antibiotics or getting any drugs in hospital, like nobody says, I'm not having this, it's big pharma. But somehow for vaccines, it's seen as something different. And, you know, the profit margins for vaccines is smaller than it is for many drugs. I mean, in the cancer world, some of the drugs are phenomenally expensive to the point where some countries just can't possibly afford them. So, so it's a different situation. And I do wonder whether we just need to turn around sometimes and say, look, it is what it is. We can't make the vaccines. If you guys want governments to make vaccines, then you're going to have to do that through the democratic process, because, you know, that's not what is going to happen in the near future. And so I think there are ways in which we could have more academia involved in the whole vaccine development world, but at the moment it's difficult. Anyway, it could take a whole policy session to talk about this further, but I don't think there's an easy solution. I think right now the solutions lie in the relationship between the healthcare provider and the patient, and that has to be really strong and really good.
Okay. Who's next?
I think that might be me.
Okay, go ahead.
Thank you so much for your talk. I have a question again, sort of around vaccine hesitancy, and in no way do I want that to diminish your earlier points about, you know, technical and infrastructural issues in terms of vaccine access and equity. So New Brunswick actually recently tried to mandate vaccination in school-age children by adjusting the legislation and removing conscientious choice, things like that. And to your point about the polio vaccine and the challenges that they're having right now with eradication, I believe it's Afghanistan and Pakistan, and that's stemming, partly it's stemming, my understanding is from people within the community, and important community figures were spreading misinformation about the vaccine, that it was going to cause sterilization, et cetera, in populations. And so it wasn't until the medical community started collaborating and working with members within the community, non-medical and non-clinical members within the community, to correct that spread of misinformation. Did we see, or are we now starting to see a shift back towards more successful vaccination programs? Unfortunately, in the New Brunswick case, there were private lobbying groups which came forward and provided testimony. I believe it was Vaccine Choice Canada, against this changing in the legislation, which is unfortunate. And so vaccine hesitancy, I think my point is it can arise from a variety of streams. Sometimes it is the person next door, it's your neighbor, it's someone you personally know and you have a relationship with and you trust, and other times it's more anonymous or removed sources like the internet or something that you read which seemingly has authority or credibility behind it. And I'm just wondering if you can speak to any different strategies, either or do you think different strategies are appropriate to address the many avenues of vaccine hesitancy? Because I don't think it has a singular face. I think it's multifaceted.
Mm-hmm. Yeah, that's a great point. And I think, Vaccine Choice Canada is, I often refer to them because they have such a brilliant website and they are so good at, what they do. I have to take my hat off to them. We've had limited success, for example, when they put up the billboards in Toronto that were anti-vaccine, which Carly Weeks picked up on. And then very quickly we had a big group of pro-vaccine people onto it and the company pulled those down. So I think having that network of highly sensitized people who are willing to act, who are willing to somehow be the counter to those voices is a piece of this whole thing. The whole thing about mandatory immunization is it does provoke those very groups. This whole thing about the Vaccine Choice Canada, the name says it all. It's this idea that somebody else telling you what to do is just an infringement of your personal freedom. It's a very right-wing ideology. It's interesting because you get this odd bedfellows because you have the right-wing ideology of don't tell me what to do, big brother, big nanny state, that reaction alongside the natural is best, loosey-goosey granola mum thing. Like it's an interesting combination of these kind of, to me, almost like the far left and far right ideologies come together around anti-vaccination. So I think having a really strong network, and there is a social sciences network in the Canadian Immunization Research Network that has some really strong people doing research in this area. I think it's a good reason to be very cautious about mandatory legislation because it does provoke those groups. And in Ontario, I know that the Attorney General's office has also, is on to their groups like Vaccine Choices Canada. So sometimes you have to also go down this legal route, but obviously, New Brunswick, it's not always successful, but sometimes it is. In California, they managed to uphold it. So, I'm not greatly in favor of mandatory when it really comes down to it. I think if we can persuade, it's a much better approach, but sometimes it just isn't an option. I could say a lot more about it, but I know there's other people who want to ask questions. So.
Yeah, and I'll just add in there for my students. This is a really interesting case of which policy instruments will work best under which situations, and is requirement or mandatory, making it mandatory the best policy instrument to use in different circumstances. Yeah, I'll just leave it there. Natasha, there's a question in the chat from Stephanie Lawrence. She's asking about surveillance. And she's just saying that she was surprised at the challenges that public health units in Ontario have faced with COVID, with contact tracing and disease surveillance. And based on your experience, what do you find is the biggest challenge with the implementation of comprehensive surveillance? Is it the issue of liberty or systemic gaps? Or maybe something else?
Yeah, interesting. I guess I'd say the question is where. In countries like Canada, the UK, like high income settings, then you get more of the pushback of people saying, how do you know my information? Why are you contacting me? Why should I tell you anything? Which I think is a shame, really. But there's a question of public education, and I was interested that, for example, the Canadian app, which interestingly, they use exactly the same app in Switzerland, how it protects privacy in a way that I think is really bizarre. When you given that, you know, public health does have the legal right to know certain information, it's very reliant on individuals putting in information and falsely reassuring. So I think we've probably gone too far in protecting people's privacy at the risk of putting public health at risk. Anyway, I don't have a solution for what we do about the kind of individualistic approach in countries like Canada. I think that comprehensive surveillance challenge in low-income settings is really basic. It's, you know, we just don't have the human resources, we don't have the laboratory resources, don't have the kits to do the testing often. You know, it's really, really basic lack of resources and people. It's all fixable with at relatively low cost. I mean, the gaps in surveillance could be fixed in a heartbeat if the money was there, and it's not a lot of money. So I don't think it's liberty. I think it's systemic gaps. In countries like Canada, liberty is going to be your issue.
Okay.
Thank you.
Okay. Any more questions on the floor?
I have a quick question, potentially kind of on the same topic of hesitancy. It was brought to my attention earlier in conversations with somebody, just when talking more about like the COVID vaccines, but I think it's relevant. The hesitancies of some groups based off of historical relations with vaccine testings on their communities. The person who had brought this up was Indigenous, and I hadn't really thought about the historical implications of hesitancies of vaccinations, or just maybe being skeptical with the process, and especially the rush that's put on things like COVID, which are so obviously pressing on a global stance right now. So I was wondering if there are specific strategies beyond the relationship of physician and person in front of them that maybe go to communicating with groups that have historically been abused in the vaccine process, and how to create relationships, like fix those relationships, and also encourage vaccine uptake within their groups as well.
It's interesting. I'm not aware of any examples where specific groups were historically abused in the vaccine process. Like, I'm aware of some terrible examples of infectious diseases related abuses in relation to syphilis and hepatitis and other things in the US. But specific examples related to vaccines, I'd love to know more about that. The issue that that is much more familiar is just that groups that are excluded for whatever reason are not going to have trust in the institutions anyway. So it's not a vaccine specific issue. It's not about the individual healthcare provider either. The numerous different groups, different religious, ethnic, whatever group has been marginalized or mistreated, or it has historical injustice, will not react well to a central group telling them what to do. Quite understandably, will not trust. And so the kinds of things that have helped in the past with those issues, which we heard a bit about with polio, is getting groups from the same communities engaged. And when I worked in London, there was an issue in the Orthodox Jewish community with getting groups immunized. And so one of the approaches there was to get Orthodox Jewish doctors who served those communities involved in trying to help with the issue. And in fact, whenever those sorts of projects get underway, and I've heard about other situations where there's a certain attitude of, oh, well, those groups don't trust because of X, Y, or Z, or there's this that problem or that problem. But then when you start working with the communities, you often find it's actually, there are other issues as well. I mean, for example, some of my European colleagues working with the Roma community, and there was always this thing about, oh, well, the Roma community, they're like these other traveling communities who don't believe in measles vaccination. And so, but when they went in to speak to the Roma community about it, they found that actually they were that many of them, the community, were quite happy to go forward and get immunized, but the problem they had was that the Roma, there's so much racism within the setting they were living in, and the services were so racist that they were treated really badly when they showed up. This isn't just about being friendly or unfriendly, this is like really a quite obnoxious behavior. And so they said, well, I don't mind getting immunized, but I'm not going to go along if they're just going to be, nasty and be rude and shout at my kids. And, so, you don't necessarily know what the problem is until you go into those communities. So the other story that I like to tell, as a colleague of mine was from the Netherlands, told me about the Bible Belts, where there's a very anti-vaccine community. But they're not as anti-vaccine as some of the Orthodox communities that have moved to North America. So there's more of there seems to be more of a mixture. Anyway, they told a story of a kid that was brought forward during a measles outbreak by a parent. And they brought their kid forward to be immunized. And they said, look, don't tell my partner, I would tell my partner that I'm bringing my kid forward to be immunized in this measles outbreak because, obviously I don't want to get into trouble with my partner, and but I really don't want my kid to get measles because I'm scared. So they said, well, it's an ethical dilemma really. But anyway, they went to get the kids' records out, and they found that the partner had already brought the child forward to be immunized and had said, don't tell my partner I'm bringing my kid to be immunized because I don't want to get into trouble. So I don't know what the ethics are, but basically both parents were on the same page, but hadn't spoken to each other about this because they thought the other one wouldn't be supportive. So anyway, what I ought to say is we don't always know what the problem is until you speak to people. And sometimes the only people who can really find out what the problem is are people from that community.
I will point out that despite Natasha saying that vaccine hesitancy wasn't the major part of the challenge with vaccine elimination or eradication, that it has taken up much of the agenda in this discussion. And so I think it is an interesting point about problem framing and what we all know about vaccination, because I think the minute that many of us hear the word vaccination, we automatically go to anti-vaxxers and vaccine hesitancy. So it's interesting. I'm not criticizing any of the questions. I think it's really helpful. Are there any other questions? I see Rachel posted something. Yes.
Yeah. Sorry, I have a question. Thank you so much for this talk. It was really informative and quite interesting. I hope I'm not diverting from the discussion, but I'm wondering what, if any, impact do you think neoliberal structural adjustment policies and program ideologies centered around privatization, deregulation, and the role of the state may have had on the spread of infectious diseases and equity? It's a big question.
It's a brilliant question. Well, I mean, my honest answer is I don't know I can answer the question. I'm even qualified to. I can give you my opinion. I mean, we're in this major crisis, and that's going to hammer the poorest of the poor, including in Canada, but around the world. And in the middle of all of this, the richest people have got richer. So, inequalities in health are bad for everyone, and inequalities in immunization make it hard to control vaccine preventable diseases. And those inequalities have laid the foundations for COVID-19 itself. The One Health approach, the environmental degradation that's gone on, the poverty that's forced people to eat animals and trade in animals that and come into contact with animals and expose the human race to infectious diseases that we might not otherwise come into contact with. You know, all of those are ingredients for what we see today. And funnily enough, this morning I was listening to BBC News, a news podcast I listened to, and they were talking about this cuckoo who had been apparently a very long, a cuckoo that's being monitored, so it's got some kind of tag on it. And it's a very sad story that this cuckoo that had traveled all over the world and been tracked everywhere and had lived longer than any other cuckoo that had been tracked, had finally disappeared off the radar. And this was really sad, and they thought it had probably disappeared because either it had been you know, caught by someone or potentially even eaten by somebody who had to catch this bird and eat it because there wasn't enough to eat in probably somewhere in North Africa. And it's this tragedy of this lost cuckoo. And I laughed aloud when I heard it, because I thought, well, isn't the tragedy the fact that somebody has to catch a cuckoo and eat it because there's nothing else to eat? Not the fact that this, like, I mean, I'm sad for this cuckoo, but really it was framed in terms of a tragic loss to bird kinds rather than a tragic loss that a bird would get eaten by somebody in that way. So it's a silly story to tell that doesn't at all address your huge question. I think the bottom line is yes, I think we have a massive problem. COVID-19 has exposed us as a species in so many ways. You know, the people who have been hardest hit, who are the essential workers amongst us, and who do we value, who do we protect? You know, the narrative at the beginning of this was about protecting the healthcare system. And I kept saying, but no, we have to protect people. It's not about protecting the system. And so, you know, we protected the healthcare system and the people died in Ontario. So I don't have an answer for you, but I think I would love you to go away and solve that one, because it's really important to do that.
Thank you.
Okay, we still have time for at least one more. Sharifa?
Yes. Hi, Natasha. Great to see you.
Hi.
Your presentation was really great. And I think regarding measles outbreaks, you have very nicely pointed out the reasons, because I think the reason measles outbreaks are very contextual. Like even in high income country or even countries with high vaccine coverage, there are pockets of suboptimal coverage. And you have mentioned that it's also a problem for the mobile population, because we've seen outbreaks like in Pakistan where cities that have very highly mobile population, there have been pockets of outbreaks. So I was wondering about one thing, like in countries, low-income countries or Africa, where there isn't any infrastructural surveillance, whether mobile phone-based surveillance could be initiated. I remember we did one for influenza surveillance back in Bangladesh, where we went to the villages and we recruited, like, you know, there are many drug shops in Bangladesh, and then the drugs are not really dispensed by professional pharmacists. It's just the drug sellers, but they sell. So that's what we did. Like, we went into the community and we recruited like maybe some teachers from the community, few teachers, few religious leaders, and then also some drug sellers. And we sort of trained them about what we were looking for. Everyone had to have a cell phone or the mobile phone, and they had to send it out to information. Like, we tried to pick up the signals when there were influenza outbreaks or something like that in the community. So maybe in situations or in contexts where there isn't any structural support, these informal surveillance systems could be instituted to pick up early outbreaks and take management.
Yeah, it's a great idea for especially for the beginning of outbreaks. If you're in an endemic setting, one of the challenges as you move towards control is that the clinical syndromes that you might use with a phone-based surveillance system become less and less reliable, because fever rash is a very common syndrome, and as measles comes under control, then all the other causes of fever rash, especially in certain settings, become more and more dominant. So as the better the control you have, the more you need laboratory confirmation. And so I can see phones being a complementary useful tool for in some situations, but it's hard to get away from the need for laboratory confirmation. And the other piece of laboratory confirmation is we also use it for the sequencing of the virus, which is a really important component of figuring out where measles is going and coming from, because you can't with the basic IgM tests, the blood tests that's done for diagnostics, it doesn't tell you which virus it is, and we use the virological sequence to be able to track the spread of the viruses between countries and within countries. So it's definitely a complementary idea, but I don't think we'd ever get away from the need for the real thing. And of course, one of the reasons that measles surveillance is in trouble right now is because it's a respiratory virus. So that lab infrastructure is really, everyone switched over to doing the COVID testing. But it also shows you how we absolutely need to have that infrastructure there so that you can switch over to doing the COVID. So it's a problem for measles right now, but if the measles labs hadn't been there, then we've been in an even more difficult situation for COVID. So I can't see it replacing, but I agree it's a really good and quick way of getting like an early warning system. And I think, as you were implying, like many parts of the world have just gone straight to mobile phones. They never went through the wired phone system. Landlines were never a thing. So it's amazingly available as a potential communications tool. So thanks for your question, Sharif. Really nice to see you.
I want to thank everybody. I want to thank all of the participants. Really lively, interesting, important, meaningful questions. I want to thank Franklin for starting us off on some stimulating questions, very briefly but very pointedly, and Xiaolin for your remarks once again. And Natasha for a tremendous, really informative presentation and tremendous detailed responses to questions. And you can see, if you have a chance to look over at the chat a little bit, how appreciative many people are. If there had been time, I wanted to ask you, but you don't have time to answer it now. But the challenges of global policy making. And how that gets interpreted when it goes down to national jurisdictions, because I'm finding that fascinating. And indeed, just yesterday or the day before, one of the students said, well, can I do my assignment on global policy making? And I said, it's going to be harder to do that than applying our frameworks to a national or a subnational setting. So another time, perhaps we can talk about that. Thank you all. And Natasha, thank you for taking the time on Friday evening to be with us. It's good to see you again, and wishing everybody a wonderful weekend. The sun is out there. And we will see you again next month at Public Health Policy Rounds. If you're not registered, then thank you. If you're not registered, you can email me at robert.schwartz@utoronto.ca to get on our mailing list. Bye now.
Thanks. Bye, everyone.